Sciences Authority, Singapore. His field of work in transfusion medicine is basically clinical chemotherapy and quality accreditation. He has numerous publications in national and international indexed journals, both in the subject of pathology and transfusion medicine. With this brief introduction, I would like to ask our speaker to start the...
Thank you, madam. Just a minute. Thank you, madam, for giving the introduction of our today's speaker. So I request our speaker to please start his presentation, that is rational use of blood and its components. Please, Dr. Asitava Debroy, please start. You can please start sharing your presentation. I think I have to stop now by sharing. Yeah, you can. Already you can share, yeah.
I hope it's visible, sir. Visible?
Yeah, it's visible. It's visible. Slide is visible.
Oh. So thank you, Maruti madam, and thank you, sir, for a very generous introduction. Only that my institution is in Kishanganj, Bihar, and not in Gujarat. So that was a small correction. Yeah. So today's topic is a very pertinent and important topic, which is not only very important for us pathologists and physicians who are practicing transfusion medicine, but a very pertinent topic for clinicians as well. So I have chosen this topic because this would be important for pathologists, transfusion medicine specialists, as well as clinicians. And I have decided to talk on this topic, dividing it into what, why, and how. I mean, what is rational use of blood and components? Why do we need rational use of blood and components? And how do we go about rational use of blood and components? So the presentation, or if we look at it as the learning objection, would be to discuss the basic concepts of transfusion medicine that are available from blood. Then the rational use of blood and its components. Now here we will discuss what it means when we talk about rational use of blood and why to practice rational use of blood. So here we will discuss about the what and why, indications of different blood components, selection of appropriate components for transfusion, and then finally some strategies for optimizing the blood component utilization. So here we'll talk about how we will practice rational use of blood and components, or how we would go about rationalizing the practice of blood component usage. So transfusion medicine, what does it mean actually? Now, this was a paper in one of the journals, Indian journal. This was a paper called Transfusion Medicine. Is it a branch of pathology or a specialty on its own? And a topic of discussion in its own. But briefly, transfusion medicine in its current form is a new discipline of medicine, quite different from blood banking. Usually, in the previous years, it used to only find a gloomy place under the Department of Pathology. But now, blood banking has forayed into the area of therapeutics. Now, blood bankers, they don't only work as a service department, but they have forayed into the area of therapeutics, also known as clinical hemotherapy, and therefore has rightly been rechristened as transfusion medicine because they deal with therapeutics. So transfusion medicine, what is it? It is a fusion of hearts between blood banking and clinical hemotherapy. So blood banking is there. Yes, blood bankers, they departments by, but they also collaborate with the clinicians in planning they plan clinical hemotherapy.
I think some audio problem.
Now coming to
some audio, there is some, it is voice is breaking sometimes. Please check the.
Okay, sir. Just a second, sir.
Sure, sure. Sometimes audio is going off and some breaking occurs.
Okay, sir.
Or is it due to the internet signal strength or?
That could be because of the network.
Yeah.
Then,
okay.
So
Otherwise,
now
it's
is
okay.
it?
Yeah, it's okay.
Yeah.
Voice is audible. Yeah, audible. Please carry on. Please.
So now then we'll talk about the blood and components. I mean, like the applications and the rational use. Now, talking about component therapy, patients have been greatly benefited from component therapy since its introduction in 1950s and 1960s. So it started in the early 1950s with administering only the required component. That is only administering the required component. So it involves the administration of minimum for the maximum required for the maximum benefit of the patient. Now it is said that blood transfusion is like marriage. Now why is it so? Because it should not be entered upon lightly, unadvisedly, or wantonly, or more often than is absolutely necessary. This simile, or the tongue-in-cheek simile from Robert Peel, has an inherent truth in it. Now, why so? Now, although blood transfusion is increasingly safe nowadays, it remains hazardous in many respects, and it are both infectious and non-infectious. So we have to be very careful when we plan a transfusion therapy, and therefore use blood and components only when the benefits outweigh the risks of blood transfusion. So that is how we can be judicious about planning the blood transfusion for a patient. Now, what are the important strategies for rational use of blood? Now, the blood components therapy, that means using blood components for the blood transfusion avoidance strategies. The one which I was talking about. That means sometimes we have to plan strategies where we can avoid transfusion unless it is absolutely necessary. We will avoid transfusion. And avoidance of fresh blood transfusion, avoidance of single unit transfusion, autologous blood transfusion, important strategies for rational use of blood. Now we'll look at
Sorry to interrupt,
one
Dr.
by
Asitava.
components. This is very basic.
Dr. Asitava?
Why do we use components?
Dr. Asitava?
Because number one, separation of blood components with. Hello?
Yeah, Dr. Asitava?
Yes, sir.
Yeah, there is some problem in the, I mean, your
Sir, I can hear you.
Yeah. The voice is completely breaking.
Yes, sir.
And some problem in your audio.
Okay, sir. Is it completely not audible?
Yeah, it was not good and not very clear. I mean, lot of it is becoming very slow and breaking. Any problem in your internet strength or in the speaker, or it was completely breaking and it was becoming very slow and very stretched out.
Okay, okay, sir. So now is it audible?
Yeah, now it is audible. Yeah, it is audible now.
Okay, so I guess it's because of the connection, but then I mean the connection, it keeps on going and coming. I mean like
Oh, it's a connection problem. Okay.
sometimes it really
Yeah, now again the voice has
yes. Mm,
uh,
Dr. Asitava, I think you need to change your microphone. Maybe some problem with the microphone.
okay, sir. Just a second.
Yeah, just please check.
Yes, sir.
I talked to him. I think he's checking the internet. Vijay Bhaskar sir? Network bandwidth is low. It's coming like that.
Hello.
Yeah, Dr. Asita.
Sir, now is it audible?
Yeah, now I think it is better, much better.
Okay, okay, sir.
Yeah, please.
Yes. So to resume, why components? So first and foremost, using components would separate blood components into different components that will allow optimal survival of each constituent of blood. So if you're separating whole blood into platelet, packed RBCs, fresh frozen plasma. So each will have different storage, storage temperatures. So ultimately, it will allow optimal survival for each constituent of blood. Component preparation will allow transfusing only specific blood component for the patient which the patient requires, and it will avoid use of unnecessary component for the patient. So if the patient requires packed RBC, so only packed RBC will be transfused and not platelet. And when the patient requires platelet, we are not transfusing the patient with packed RBC and overburdening his cardiac system. 1 unit of donated whole blood can be useful to multiple patients. And using of blood components will add to the blood inventory. So that is how the use of components is useful to blood bank as well as for the patients as well as for the donors. So what are the blood components that are available? The blood components that are available are packed RBCs, platelet concentrates, fresh frozen plasma, and cryoprecipitate mainly. Also, we get cryo-poor plasma. So these are the basic components that are available from a unit of whole blood. So it's very simple to separate a blood unit into components. The simple principle is if we take a sample of blood in a test tube and centrifuge, basically the blood separates into 3 layers: the topmost layer of plasma, the middle layer of buffy coat, which is composed of WBCs and platelets, and finally the bottom layer of RBCs. So if the same principle applies to separation of components. If we take the blood bag and centrifuge it into a cryocentrifuge, so finally we get the 3 layers of the components: plasma, platelets, and RBCs, and we separate them into 3 different bags. That is the basic principle of separation of blood unit into components. But there are few guidelines for preparation of components. We have to have a clean and aseptic venipuncture. During blood collection, you have to have an uninterrupted flow of blood. Collection should not take more than 8 minutes. If it is more than 8 minutes, we usually do not take that blood for preparation of components. We usually store it as whole blood, and components have to be prepared within 6 to 8 hours of collection. So if we are collecting it at a certain point of time, we have to keep in mind that within the next 6 to, if you want to make it into components, we have to make it into components within the next 6 to 8 hours. If 8 hours elapses, we usually do not prepare components from that collected unit of whole blood. So rational use of blood usually signifies the right product in the right dose at the right time and for the right reasons. So that in a simplified version or a simplified way, this is what it means. So red cells are usually used when the oxygen carrying capacity is low, for example in anemia. Platelets are used for thrombocytopenia. FFPs are used for multiple clotting factor deficiencies, and cryo for usually for hemophilia A. So only you give what is needed. Storage temperatures are different for different components, and that is what I wanted to say in one of my previous slides, that when we separate the whole blood into different components, it actually allows the components to for their optimal survival, because we see here that PRBCs or packed RBC has a temperature storage temperature of 2 to 6 degrees centigrade and a shelf life of 35 or 42 degrees 35 or 42 days, depending on whether it is being stored with a nutrient solution or not. For FFP, it is stored at minus 30 degrees centigrade for 1 year. Platelets has the shortest shelf life of 5 days, and it is stored at the normal AC temperature of 22 to 24 degrees centigrade. Cryo has the same shelf life and storage temperature as that of FFP. So that is the about the storage of the blood components. Now this slide is very important because there is always a dilemma or a controversy as to why 1 unit of PRBC is better than whole blood. Or maybe some may even have a debate as to why whole blood is not better than PRBC. Now let us look at it mathematically. Now, 1 unit of whole blood usually has a standard volume of 400 ml, and the hematocrit or the PCV of that unit of whole blood is 35%. Okay. Now, so the volume of red cells, simple mathematics, volume of red cells received by that patient with 400 ml of whole blood would be 35% of 400 ml, simple. So that is 140 ml, because the hematocrit is 35%, volume of the whole blood is 400 ml. So this is 140 ml, is the effective volume of red blood cells that the patient is receiving. On the other hand, PRBC that we collect has a standard volume of 280 ml, and the mean hematocrit of PRBCs are usually around 70%. Okay. So effective volume of red cells received by the patient with 280 ml of PRBC would be 196 ml. 70% of 280 ml is 196 ml. So when you are transfusing a patient with 1 unit of PRBC instead of 1 unit of whole blood, so you are actually effectively transfusing 196 ml instead of 140 ml. So you are giving 56 ml of red blood cells extra. Effectively, you are giving 56 ml of extra red blood cells. That means 56 by 140 into 100 is 40% greater benefit to the patient. So now there should not be any controversy regarding whether whole blood is better or 1 unit of whole blood is better or 1 unit of PRBC is better for a patient when a patient requires blood. So this is a mathematical calculation which shows that always 1 unit of PRBC gives a better outcome in a patient when transfused. Other advantages of whole blood versus packed red cell, since the whole blood contains plasma and packed RBCs are devoid of plasma, so whole blood will have more ABO antibodies because of presence of antibodies. Because of presence of plasma, they will have more ABO antibodies, and because of presence of plasma, they will have more plasma citrate, more allergic reactions, and more incidence of febrile non-hemolytic transfusion reactions. So these are, since packed red cells do not have are devoid of plasma, these complications are less with packed red cell. So that is why that again packed red cells are superior to whole blood. What do we mean by rational use of blood and components? This I have already said, that patients should be transfused only when there is absolute indication and when benefits of transfusion outweigh the risks of blood transfusion. So we have to assess, we have to see whether actually the benefits are more than the risks of blood transfusion. Only then we will decide to transfuse. So how can we be judicious? So there are some transfusion avoidance strategies which we can plan. So what are these avoidance strategies? These are usually in collaboration with the clinicians. So clinicians always have to support the transfusion medicine physicians when we are planning these strategies. And this is a part of what I was calling it's the clinical hemotherapy. So we have to assess the underlying cause of the low or altered blood component needing replacement rather than just blindly replacing the same. So we have to see what is the cause of the altered blood component. Here I would like to give an example, like if the thrombocytopenia is because of immune thrombocytopenia, so there would be no point transfusing the patient with platelets. So that is one thing that we have to keep in mind. Deferring surgical events that can be conserved till sorted out can prevent unnecessary transfusion. So maybe if you see that because of mild anemia, you are not being able to conduct a surgery, and rather than transfusing the patient and taking him or her for the surgery, you can just defer the surgery till the time the patient recovers from his or her mild anemia. Use of autologous blood transfusion, I'll come to this again. Use of erythropoietin, iron, vitamin B12 replacement to increase the hemoglobin rather than transfusing him with blood and components, and use of vitamin K rather than FFP to correct altered prothrombin time. So these are some strategies where you can, which you can plan to avoid transfusion of blood and components. What is autologous blood transfusion? Now, autologous blood transfusion is a blood collected from a patient for retransfusion at a later time into the same individual during his or her surgery. So what happens is so when the patient is receiving his own blood, so he gets the safest possible blood. So there are three types or three categories of autologous blood transfusion. One is the pre-operative donation. Second is acute normovolemic hemodilution, and third is blood salvage, of which the pre-operative donation is the most commonly used one. What happens is the patient comes, when you plan a surgery, maybe 4 weeks later, so the patient comes to you at a particular period of interval of time. The patient, you call the patient to the blood bank, and he comes at a definite frequent interval of time, comes and donates a certain amount, and that blood is kept in the blood bank for use when he is taken up for surgery. So that is how you plan his surgery, and that is called autologous blood transfusion. The patient's blood itself is kept for his own use. Next is avoidance of single unit transfusion. Now this is very important. Now many a times you will see that we have to keep in mind that 1 unit of blood just increases the hemoglobin by 1 gram%. So, and majority of our hospitals in the country are using single unit of blood in about 30% of the cases. And even in many of the hospitals where I have worked, I have seen that many a time the requisitions come to us in the blood bank, which ask for only a single unit of blood. Now, this, if the patient requires, if the clinician feels that the patient requires only 1 unit of blood, then maybe that mild blood loss or mild anemia can be treated with, can be managed by colloids or crystalloids itself. Why to use or why to go for transfusion? Now, if we have to think it in a different way. When a person can donate 1 unit of blood without any side effect, then a patient can also bear that blood loss without any side effect. So if you feel, if the clinician feels that the patient has if patient will recover with 1 unit of transfusion, so that may not be right always. So 1 unit of transfusion will actually not have any benefit in the patient. If at all the patient requires blood, then maybe he will require 2 units or more. Single unit is equivalent to no transfusion. It is said that single unit transfusion is equivalent to no transfusion at all. So either if you are actually planning for transfusion, you have to, the patient, if you feel that the patient actually requires transfusion, it has to be 2 units or more. And if you feel that the patient requires a single unit transfusion, then you again maybe have to go back and look into the papers of the patient, look into the patient and also the papers of the blood parameters and the laboratory reports, and see whether actually the patient requires transfusion, and assess again whether the patient actually requires transfusion. Now, what are the problems faced in planning transfusion therapy? Inappropriate requests for transfusion. Now, this is one of the main problems that we face. Inadequate information in requisitions. Now, if the requisition forms are not properly filled, then it becomes very difficult for the blood bank, even the technicians, and as well as the blood bank doctors, the transfusion medicine physicians, to decide what actually the patient will need. Now that concept of actually writing down requisitions and getting whatever the clinician demands is actually out of date. Basically, the clinicians, I mean, it is now the era of transfusion medicine, which I was talking about, where the clinicians should actually discuss and plan a therapy together. So if we are not getting proper information, like for example, in a case of anemia, if I do not know what actually is the hemoglobin level of the patient, it becomes very difficult for the blood bank to decide, I mean, how many units of blood the patient should actually require. Misconception of transfusing whole blood that I have already, I guess I have been able to, get rid of that misconception. And choice of alternative blood groups in case of non-availability of specific group components. This is again important. Sometimes it becomes very difficult to convince the clinicians that if the specific group components are not available, then maybe we can use other group components as well. That has to be, there has to be that much of, I mean, the clinicians have to have that much of confidence in the transfusion medicine department or the doctors in the transfusion medicine department while choosing these or while planning the therapy when the particular group of components are not present in the blood bank. And the most important thing is lack of communication between the clinician and the transfusion physician. Fresh blood transfusion. Now, fresh blood transfusion, this is one of the myths that has come, I mean, like, I don't know how it has been, this has been percolated through, I mean, through years, and people have been insisting on the use of fresh blood transfusion, but this is a myth. Use of fresh blood transfusion should be avoided. Why? Because what do you mean by fresh blood? Fresh blood means you collect and you give it to the patient. So that if you want to give fresh blood, it will be untested or inadequately tested. So would you want to give up untested or inadequately tested blood to the patient? That would only increase the risk of transfusion of viral infections from fresh blood. So the only justification of giving fresh blood is because fresh blood contains higher levels of 2,3-DPG. So because the 2,3-DPG has higher oxygen carrying capacity, maybe you want to give fresh blood because that would give you a better oxygen carrying capacity. But we have to also remember that these 2,3-DPG levels, they return to normal within 24 hours of transfusion. So it should not be like Bollywood movies where one person lying down and donating blood, and the same time the same blood is being transferred to another person who is lying on the other bed. So I mean, as fresh as possible is not possible actually. So what can be the only indications of fresh blood transfusion? Newborns may sometimes require fresh blood as they have high percentage of fetal hemoglobin, and fetal hemoglobin, as we know, does not release oxygen as promptly as adult hemoglobin does. So as I told you that since fresh blood contains higher amount of 2,3-DPG, so maybe we may consider giving fresh blood to newborns. But this recent study, I mean, not very recent though, in 2012, it has this age of red blood cells in premature infants. This trial, it showed that this is not true, showed no difference between fresh and standard RBCs. Okay, this was published in JAMA. So this trial has showed that there is no difference between fresh and standard RBCs. So ultimately, you don't even have any indication of giving fresh blood in newborns as well. Sometimes patients with impaired cardiac function may require fresh blood. Now, the indications of specific components. Coming to the indications of specific components, these are some basic points for the sake of completion. Whole blood, we know that we require for acute blood loss with hypovolemia, in exchange transfusion, and these are the two main reasons why we require whole blood nowadays. Only when there is an acute blood loss, like for road traffic accidents, for any injuries, and in exchange transfusion. So these are the two absolute indications for whole blood. Other than that, we do not use whole blood anywhere. Third point can be, if a blood bank does not have packed RBCs, then we can use whole blood. What are the indications of packed RBCs? Replacement of red cells in anemic patients, or sometimes used with crystalloid replacement fluids or colloid solution in acute blood loss. Now, sometimes there are, the second point is important, where there are some blood banks who do not practice the use of whole blood at all. Now, I have worked in a blood bank where they practice 100% component therapy. Now, when there is 100% component therapy, that means there is no use of whole blood at all. So what will you do when a patient has acute blood loss? What will happen when a patient of acute blood loss comes to that hospital where there is no whole blood? So you have to replace the volume, right? Only giving packed RBCs will not do. So that time you will use packed RBC. Along with that, you will use crystalloid replacement fluids or colloid solution. Colloid solution for managing the acute blood loss. So the second indication is use of packed RBC along with crystalloid replacement fluid or colloid solution for managing acute blood loss. Next, coming to platelets. Platelets first can be because of treatment of bleeding due to thrombocytopenia or platelet function defects, or prevention of bleeding due to thrombocytopenia, such as in bone marrow failure. So these are the indications of platelet transfusion. FFP is given in replacement of multiple coagulation factor deficiencies, for example, in liver disease, warfarin overdose, depletion of coagulation factors in large volume transfusions or massive transfusion, vascular coagulation, and third is TTP or thrombotic thrombocytopenic purpura. Finally, cryoprecipitate. It is an alternative to factor VIII concentrate because cryo is rich in factor VIII in the treatment of factor VIII deficiency or hemophilia A. Also in von Willebrand factor disease von Willebrand factor deficiency or von Willebrand disease, and as a source of fibrinogen in acquired coagulopathies, because cryo is also a rich source of fibrinogen. Now coming to the doses of individual components, PRBC, 1 unit prepared from 450 ml of blood is expected to raise the hemoglobin by 1 gram% in patients who are not bleeding. Platelets, 1 unit will raise the count by 5,000 to 10,000 per cubic millimeter. So usual dose is 4 to 6 units. And FFP, the usual dose is 10 ml per kg of body weight. Now coming to this important part, as I was talking about, choice of alternative blood groups. What happens if a patient of A group is bleeding and the blood bank does not have A group blood or A group component? So do we let the patient bleed, or do we let the patient not have a transfusion? So let us see how we manage those patients. Now, when we come to look at these PRBCs should be ABO and RH compatible. So it has to be both ABO compatible and RH compatible. In emergency life-saving situation and in cases of non-availability of specific group component, O negative may be transfused to patient of any group. So O negative is a universal donor. So we can give O negative blood to anybody. In case of non-availability of O negative blood, the following alternatives may be given in life-saving situations. Now, what are these? So if a patient is of O blood group, the first choice is O, there is no second or third choice. If the patient's blood group is A, first choice is obviously A, second choice is O. If the patient's blood group is B, first choice is B, second choice is O. If the patient's blood group is AB, first choice is AB, second choice is A, and third choice is B. Okay. In cases of platelet transfusion, now this is important.
Dr. Asita? Yeah, looks like some technical issue from the speaker side. I think he is trying to rectify. Let's wait for some time. Eh,
Dr. Kiran, any technical problem?
yeah, Dr. Asita, some technical issue.
Okay, yeah.
Yeah. I think he's again trying to reconnect. Let us see.
Is my screen visible?
Yeah, it's visible. It's visible.
Yes, sir. There was some again disruption, I guess.
Yeah. Okay, no problem. Please continue.
So regarding this platelet transfusion, what I was saying is ABO compatibility is of minor importance. So in adults, we can actually go ahead with platelet of any group. However, in children, we usually look into, we usually transfuse platelets of the same group. I mean, it has to be ABO compatible platelets in cases of children. So choice of groups in platelet transfusion. So if it is of O, if you are having the platelets of the same group, it is advisable to go for the same group platelets. If not, second choice is A, third choice is B, and the fourth choice is AB. If it is A, then first choice is obviously A, second choice is AB, third choice is B, and fourth choice is O. Similarly for B, it is first choice B, second choice is AB, third choice is A, and last choice is O. And AB, first choice is AB, and similarly second choice and third choice are A, B, and O respectively. For FFP transfusion, FFP, now plasma of the same blood group as that of the recipient is preferred. So ABO compatibility is required in cases of FFP. However, RH compatibility is not required in cases of FFP transfusion. So we can transfuse RH positive plasma to RH negative patient and RH negative plasma to RH positive patient as well. So choice of groups again in FFP plasma, FFPs. Now, AB plasma is a neutral plasma. So obviously the second choice in for all the cases is AB plasma. So first, if the patient's blood group is O, the first choice is always the patient's blood group. But the second choice, if you see here, is always AB, because AB is a neutral plasma. It does not contain any antibody. So that is why the second choice is always AB here. And third choice, accordingly, we have A and B respectively. In cases of cryo, again, ABO compatibility is preferred, but is not that important. RHD need not be considered like that of FFP. Now, choice of components in RH system. Well, obviously, when RH negative component is not available for transfusion, then what should be our priorities? So, if RH negative component is not available for a RH negative recipient, we have to look see if it is RH negative woman who have not crossed the childbearing age, then we have to RH negative component should only be given to avoid transfusion reaction in future and hemolytic disease of newborn in subsequent RHD positive baby. And in RHD negative male, or if in RHD negative female who has crossed the childbearing age, then RHD positive component may be given rather than withhold the patient for those whose need is critical, provided that RHD antibodies have never been detected in the recipient serum and no antibody is found in the test serum on screening with Coombs test. And obviously when the blood is compatible. So there are two situations when the when the patient is RH negative, and obviously the she has not crossed the childbearing age, and when the patient is RH negative and she has crossed the childbearing age. So our policy should be to turn negative into positive. Now this should be the policy also in our lifestyle. So this should be our policy even in the blood bank. So what is this policy? We can very well transfuse RHD negative blood to RHD positive patient. Many a time I have seen that clinicians are reluctant to take negative or transfuse negative components to positive patient. Now that is, I do not know why there is a reluctance or hesitance in the part of the clinicians to not use negative blood for positive patients. We can very well, because they are they do not have those RHD antibodies. So what is the problem? So we can very well transfuse RHD negative blood for RHD positive patient. A negative, for example, A negative blood can be given to A positive, B negative blood can be given to B positive, but usually not the reverse. Coming to optimization of blood usage, how do we optimize blood usage? Now this is very important, and this is the era where we want to optimize blood usage, and here we would actually need the help of our clinician friends for optimizing the usage of blood. Just looking at the background of it, we have seen that pre-operative ordering of blood is a common practice in elective surgical procedures based on worst case assumptions. Usually the clinicians fear that the patients might end up bleeding during the surgeries, and that is why with that apprehension, what happens, there is pre-operative ordering with potential exhaustion of blood bank resources. So even the clinicians fear that their patient may end up bleeding, so let us reserve some blood for the patient. So they end up ordering a lot of blood pre-operatively. So what happens because of that? There is exhaustion of the blood bank resources. So the time and effort consumed in cross-matching for each patient undergoing a surgical procedure is substantial, most of which is actually not utilized. So what we do, when the clinicians order, they order as cross-matching of, suppose example, 4 units of blood for a particular surgery. Now what you do, the blood bank takes out those those blood units from the blood refrigerator, does the cross match and keeps it in reserve for the patient. So those blood units are kept in reserve. So any blood bag which is extracted from the blood bank inventory or blood bank storage for cross matching becomes unavailable for other patients. So now if you suppose the patient was of a rare group, B negative, and the clinician had asked for 4 units of B negative blood. So you take out for those 4 units of B negative blood, cross match it and keep it in reserve for that surgical patient who has, the clinician feels would require during the surgery. Now what happens is the patient did not ultimately did not require any blood. And in the meantime, there is a patient who comes to the hospital with acute blood loss and requires B negative blood. Now the cross-match blood which is kept in reserve for the patient for the surgery, you will not be able to release it for the patient who has come to you with the acute blood loss, because that has been kept in reserve. So that becomes unavailable for a patient who is actually serious. So once cross-matched, the blood bag is held in reserve, ensaving inventory problems for the blood banks, loss of shelf life for that blood unit, and wastage of blood unit sometimes. Okay? So how do we go about solving this problem? So if unnecessary blood orders can be reasonably cut down, it will reduce both workload and financial expenditure. So we would want that this unnecessary blood orders can, if they can be cut down. So for that, we need a review of the surgical blood ordering practice. We have to review what is being practiced in the institution. So for this, a number of indices are used to determine the efficiency of blood ordering and utilization system. So basically, to review the ordering practice from the clinics or basically from the surgical wards, we use certain indices. And these indices are cross-match to transfusion ratio, or you also call it CT ratio, then transfusion probability and transfusion index. So these are used to work out this surgical blood order schedule. Now, what are these indices? We'll look at it one by one. So CT ratio, this was put forward by Borel Henry, who suggested the use of CT ratio in 1975. And this is actually the number of units cross-matched divided by the number of units transfused. Okay, I'll show you with examples what it actually is. Now, ideally this ratio should be 1, but it has been decided that a ratio of 2.5 and below is indicative of efficient blood usage. So if it's 2.5 and below, so it is ideal. So this is the reference from which actually this CT ratio comes. Next is this transfusion probability. Here it is, when we talk about it in percentage, the number of units transfused by the number of patients cross-matched. This is actually the reverse in terms of percentage. So the probability of transfusion for a given procedure was suggested by Mead et al. In 1980, and the value of 50% and above has been suggested as appropriate. So value of percentage, value of this transfusion probability is 50% and above. And finally, this transfusion index. It is number of units transfused by number of units cross-matched. I mean, it is similar to transfusion probability, but not in terms of percentage. It is just a simple ratio, and it signifies the appropriateness of numbers of units cross-matched and a value of 0.5 or more is indicative of efficient blood usage. That is, I mean, as you saw in transfusion probability, it was 50% or more. Since it was in percentage, since it is ratio, it is 0.5 or more. Simple. Now, let us look at the statistics here. If I see, this is the blood requisition statistics in my institution. Now here, if I see here, let us take look at it one random statistics here. Now here, these are all requisition statistics. That means how many components have been asked for from the clinics. Suppose I take example of the month of March. So 5, 189, 36, 26, 256. Okay, so 256 is the total number of units that were asked for in the month of March. And actually, the components that were used in the month of March were 185. Okay, so what is the CT ratio for this? So if we calculate, what comes out to be the CT ratio? 256 divided by 185 comes out to be 1.38, right? So, and what was the this thing here? What did we say? 2.5 and below was suggestive of indicative blood efficient blood usage. So 1.38, if we have got the ratio of I mean CT, that means the blood usage was more or less efficient. Similarly, if you calculate the others too, you will see that almost the transfusion, I mean the CT ratio is I mean moderate, more or less less than 2.5. So I mean thanks to our clinician friends here who are actually not over ordering the blood or components, because of which we are being able to maintain the CT ratio. Now coming to one more important thing is one important aspect of this is maximum surgical blood order schedule. What is this maximum surgical blood order schedule, or MS-BOSS if it is called in terms of its abbreviation? So a maximum surgical blood ordering schedule is a mechanism to maximize usage of blood and minimize wastage in elective surgery. So if you are planning an elective surgery, we usually use this maximum surgical blood order schedule. So this can reduce the workload of unnecessary cross-matching and issuing of blood and optimizing the stock management, as I was talking about. So there is no assumption, or there is no, because I mean, there is no unnecessary usage or unnecessary cross-matching of blood. Here mathematically we calculate how many units of blood will actually the patient require in case of a particular surgery, and that is how a schedule is prepared, so that suppose I am planning a surgery, suppose a laparoscopic or a open cholecystectomy or whatever. So how many units of blood the surgeon will require is pre-planned. So according to that MS-BOSS, I will keep that many units prepared for that particular surgery. So this MS-BOSS and means criteria. So there is, so MS-BOSS is used to promote auto reduction of blood requests, thereby increasing efficient blood ordering practice for surgical patients. And it has been used since 1975. So the initial formulation of MS-BOSS was done using Mead's criterion. And what is this? According to this criterion, the number of RBCs calculated was 1.5 times the transfusion index of each surgical procedure. Now, I had already discussed what is transfusion index. So 1.5 multiplied by transfusion index is actually the number of RBCs that would be required for that particular surgery. So Mead's criterion was used by Vibhuti et al. To establish a MS-BOSS for elective surgical procedures. And so this is the criteria: MS-BOSS equal to 1.5 into transfusion index. So MS-BOSS is basically used to promote efficient use of blood inventory so that unnecessary blood resources are not wasted. Avoid outdating of blood units. So sometimes it so happens that you are cross-matching blood and keeping it in reserve for some patients, and ultimately the patient does not require, and in the meantime the blood units expired. So that is avoided. Reduce pre-transfusion testing, minimize unnecessary cross-matching, because these are all these requires some cost, some expenditure. So that will be reduced. Provide a guide for autologous testing and enhance the quality of care. So all these are advantages of using MS-BOSS. So what you do then, you can adapt a group and save policy. What is that? The notion of group and save policy has been utilized since many years, and many authors have shown that merits would outweigh the alleged demerits. Now, there was a study conducted by AIIMS New Delhi, and it was seen that when the number of units calculated for any surgery is less than 0.5 units, a group and save policy would be ideal. That means, what is this group and save policy? Suppose you don't cross match. You just, suppose you see that only 0.5 units or less are required for a particular surgery. You just group the blood and keep it, because cross matching will incur some cost and also will keep the blood, it will just store the blood or keep the blood in reserve for the particular patient. But if you are doing grouping and just do the grouping and screen it for antibodies and save it, so that would suffice for that particular patient. So no pre-surgical cross-match would be done. Instead, grouping followed by screening for antibodies is performed in this policy. Therefore, it is crucial for every institutional blood bank to formulate a blood ordering schedule or a maximum surgical blood ordering schedule. Clinicians should take initiative to order blood for the scheduled procedures in accordance with the devised MS-BOSS for the appropriate usage of blood resources. It should not be so that the MS-BOSS has been prepared and kept in some cupboard, and nobody takes, looks into it for ordering blood. So that should not be the case. There has to be initiative from both the clinicians and the transfusion medicine physicians to work in accordance with that MS-BOSS. Regular auditing and periodic feedbacks are also vital to improve the blood utilization practices. Now, these audits are very important. Unless there is auditing, there is no scope for improvement. So medical audits are a part and parcel of anything that functions, and also the functioning of blood bank. So we have what do they help in? They help in systematic critical analysis of the quality of medical care. It improves the processes in ordering, distribution, handling, and administration of blood. And the guidelines of medical in the field of medicine, guidelines keep on changing. So guidelines for transfusion can be reviewed from time to time and modified if required. So medical audits will help you in this. And auditing and monitoring can reduce the unnecessary transfusions and promote component therapy. So when you are auditing and monitoring, and if you just happen to see that sometimes that unnecessary transfusions are still continuing, or sometimes component therapy is not being implemented, so maybe you can make some corrections. Then it is very important to have a hospital transfusion committee in the institution, because it is the hospital transfusion committee that will monitor or that will audit the blood bank. So it is the responsibility of the hospital transfusion committee to review the blood usage, blood ordering strategies, and active interaction amongst the blood transfusion service and clinicians. And it is always important that the chairman of the hospital transfusion committee should be somebody from the clinics. It is not so that the blood transfusion, blood bank in charge or the transfusion medicine in charge is the chairman of the hospital transfusion committee. It is usually the critical care in charge or the anesthesiology department professor and HOD is the hospital transfusion committee in charge. So and there are other members, maybe the member secretary is from the transfusion medicine, and then there are other members from other clinical departments, the nursing superintendent, the infection control nurse. So all these people, important people, they comprise the hospital transfusion committee. So HTC helps in appropriate utilization of blood, promotion of autologous blood transfusion, and promotion of use of components. They can also frame guidelines to run the blood transfusion services and its effective utilization. So they can have their own policy, so institutional policy for transfusion and its effective utilization. So to summarize, component therapy is the demand of the hour in clinical medicine. Rational and judicious use of blood components is beneficial to the patient as well as in generation of resources in the blood bank. So planning of transfusion therapy should be mutually coordinated between the requesting clinician and the transfusion physician. So I feel this is the last one, which is the most important. That is why we have to work as a team. The clinicians, the transfusion medicine physicians, we have to always work as a team, because it is said that together everyone achieves more. And that is what is meant by the word team. So thank you for your attention. That was all that I had to say. And with all the interruptions in between, I'm sorry for all the interruptions, which was all unintentional. Thank you all. Thanks, everybody. Thanks a lot.
Yeah, thank you, Dr. Asitava, for the wonderful presentation. Next, yeah, now the session is open to all the participants. They can freely interact with the speaker. So one by one, you can ask the questions or any doubts you have, or anything you want, any participant wants to say anything on this topic, please. Yeah, please unmute and ask your questions and interact with the speaker, please. I think while the session was going on, someone was raising their hands also. So
yeah, I saw some hands raised. Yeah.
Yeah. Any questions from anyone?
Dr. Kiran, can I ask one question?
Yeah, sure.
Yeah. Dr. Asitava.
Yeah.
Yeah. Thank you very much for your detailed discussion on rational use of these blood and blood products. I have one question for you. In this COVID scenario, what is your experience with the plasma therapy?
Sir, plasma therapy, you are talking about this convalescent plasma donation, right, sir?
Yeah.
Yes, sir. So basically here we were not, not doing plasma therapy here, because for that we require a FRSS setup, as you know. Although in West Bengal, they had been allowed, collecting plasma from COVID recovered patients, even without apheresis. Random collection of platelets from COVID recovered patients. But then in other states, this was not allowed, and ideally it should be collected through the process of apheresis. So we in our college, since we do not have a apheresis setup, so we did not go for collection of plasma in case of COVID recovered patients.
Any more questions?
Sir, can I ask one?
Yeah, sure.
Sir, it was a very good presentation, sir. Wonderful presentation. I used to acknowledge this. I have got a question. There is a scenario where the first choice blood is not available. Now we have got second choice blood. We are ready to give the second choice blood. That now yes. The clinician is also expecting us to do the same. Now the question is, ABO blood group antigens are present not only on RBCs. We all know that it is present even in smaller tissues and also cells like endothelial cells, platelets, everything. Yeah, even neurons also. Some of the journals give that. Would
Yes,
it
sir.
cause any problem? Means like, would it cause any reaction for the tissues as such? That I wish to know. And in this case, in that scenario, should we take any risk consent from the one who wish to transfuse?
So you're talking about which component? Any component?
Yeah, for example, especially we face this problem with platelets, but you told platelets in adults will not have any much problems. Sir.
Sir, platelets, as I told you, it is only about 15 to 30 ml of component that is being used. And as we know, the total blood volume is around 5 liters in an adult. So that is why I mentioned adult. So
Okay,
5
sir.
liters. So when I am using 15 ml, 15 milliliters or 30 ml at the maximum. So 30 ml of platelet, when it goes into the adult body, so it mixes with 5 liter of the blood volume. So it gets diluted.
Okay, sir.
The dilution is of that level. 30 ml gets mixed with 5 liters. So it gets highly diluted. So that is why we say that those antibodies that are present in 30 ml of blood, it gets so diluted to that extent that it will not cause any harmful effect in adults.
Okay, sir. Sir, same scenario. What about PRBC?
PRBC, sir. PRBC, it is always preferable to give ABO compatible PRBCs. And if not, in
If
life,
not,
always ABO compatible. I was talking about second choice PRBCs only in life-threatening situation. You would always want to save the life of the patient. There may be some comorbidities which the patient might have after the transfusion, but you have to assess whether you want to save the life of the patient or you want to, have some problem. You are okay with some problems which the patient might have once the patient survives.
okay, sir. In that scenario, can we have? Is it better to have risk consent?
Obviously, sir. Obviously, you are everywhere. You before transfusion, even when you are giving same group transfusion, you have to take a consent.
Thank you, sir. Thank you.
Yes.
Yeah, any more questions from the participants?
Dr. Raj here from CGH.
Yeah, Dr. Raj, please carry on.
Yes,
Go ahead.
how are you?
Fine, Dr. Raj, please.
Excellent presentation by Dr. Asitava. He has mentioned the rational use, which are actually, it's a good topic also to be discussed. I just wanted to know, in case who goes to patient, it's an autoimmune hemolytic anemia, and nothing is coming compatible. Any group that we do cross matching is incompatible. Sometimes 1+, sometimes 2+. So then what is the best choice? What do we do in that scenario?
So it is the guideline is to supply or transfuse the least incompatible blood.
Right. Okay. So that is the guideline. That means we have to cross match with multiple bags. And
Yeah.
as you said, maybe about 4 bags or 5 bags, and then see which is least incompatible.
Least incompatible blood, slow transfusion under supervision.
Right, sir. Thank you.
Yeah, Dr.
Thank you.
Raj happens to be the blood bank medical officer. So good question
Okay.
from you, and
Okay.
thanks for your participation.
We have a lot of cases like that, sir. Once or twice in a month we face such scenarios.
Yeah, I understand.
So sometimes after using steroids, usually the compatibility is at a better rate, and then we give about 1+. That's what I issue. So, right, sir. Thank you.
Thank you.
Thank you, Dr. Kiran,
Thank you, Dr. Raj. Thank you.
for arranging it for our appointment. Thank you.
Anyone else wants to interact with the speaker, or any questions or any suggestions or any opinions? Yeah, I just want to say, Dr. Asitava,
Yes, sir.
That you stressed upon the fact that there are actually practically there are very few indications for whole blood transfusion.
True, sir.
So mostly we should go for components only, depending on the indication.
Yes, sir.
So that is I think a very important advice suggestion.
Yes, sir. Yeah, actually, ideally, what we started, sir, I mean, in my previous institution where we also work together, and I also here, I usually tell them to keep two units of the same group, like two whole blood of group A, two whole blood of group B, like
Yeah.
that. I mean, minimum number of whole blood, so
Yeah.
that if there is any case of acute blood loss, we can manage that with whole blood. Rest, I mean, like I always advise that the rest of the component of whole blood that we collect, blood units that we collect, can be separated into components. I mean, the least thing with the least we can do is we can separate it into PRBC and plasma. We do not always separate into platelets because many institutes may not require platelets. I mean, the demand may not be that high because the big demands differ from institute to institute. So platelets, depending on the demand, we can prepare platelets. Otherwise, we can just separate into PRBC and plasma and keep it for our use.
Yes. Yeah, I think I appreciated one point that about the hospital transfusion committee you told. Na? I think
Yes,
nowadays, I think practically everyone is following that, maybe. Transfusion committee and framing their own policies. That really
most
helps.
of the yes,
Helps a
sir.
lot.
Yes.
And
Yes.
a lot of awareness is required from the clinician side also, so that we should make them more aware of these things.
Actually, sir,
Exactly, that's very important.
that concept of only treating blood bank only as a service department, I mean, should be, I mean, actually, they should get away with that idea.
Exactly. So we need a lot of clinicians cooperation for this to avoid wastage of blood and also optimal use of blood. This is very important.
Actually, sir. Yes, sir.
Any more questions from anyone? If there are no questions, yeah, someone, Dr. Shahbaz Karim raised a hand. Please, Dr.
Yes,
Shahbaz.
sir. I'm Dr. Shahbaz Karim. Sir, I just want to know that in case of second choice, if a patient is having AB blood group and we are using a second choice transfusion, like we are using B in that B group blood in that patient, should we take any prior precaution in such circumstances, sir?
You are talking about PRBC?
Yes, sir. Yeah, sir. I am talking about PRBC. If the patient is having blood group AB positive, and unfortunately we do not have available A positive blood group, and we are transfusing the second choice, the B blood groups, B positive blood group. Should we take any prior precautions? Should we take any prior medication so that we have to avoid any reactions or something else like that, sir? Should we take any prior precautions, sir?
No, there is no guideline as such for, taking such, I mean, you are using such kind of a second choice only in case, as I told, only in case of a life-threatening situation where the patient is bleeding to death and you are not having any other alternative than to give that unit because you want to save the life of the patient. So you are taking, as such, you are taking a risk because you just want to see that whether you can save that life of the patient, and the only option that you have is to transfuse the patient with that unit of blood. So you are anyway taking a risk. The only thing is that you have to take a consent, and consent is anyway you have to, for any blood transfusion, you need to take a consent.
Okay, sir. Okay, sir. There is no like such type of consent that in we do not have available A group, so we are transfusing the B group. We are not taking such type of.
No, that you have to mention. I mean, that you have to tell the patient party, obviously. But that consent, I mean, consent you have to anyway take from the patient party. But in that life-threatening situation, obviously you have to inform the patient party. Not only the patient party, also the consultant who is treating the patient. You also have to inform the consultant that you do not have that particular group and you are transfusing. Because, as I told, that therapy should always be planned in consultation with the clinician.
I think that answers this question.
Dr. Karim, am I clear to you?
or maybe he's out of signal or something like that. Yeah, any more questions? I think there are no more questions or interactions from the participants. We can move on to the other formalities. Like next, I request Dr. Kumar Guru to please convey his heartfelt vote of thanks, especially to the today's speaker.
Good
Dr.
evening.
Kumar, yeah, please.
Good evening, everybody. I congratulate today's speaker, Dr. Asitava Debroy, sir, for enlightening all our virtual audience about the rational and judicious use of blood and blood components. Sir, it was not only important topic for postgraduates, but also it was it was high pragmatic value for the routine practice, that is blood transfusion practice. Also, it is a very fast developing field. We have to update our knowledge, and at the same time we have to reinforce whatever we have learned. You made our concepts very clear and crystal clear, sir. Thank you for that very much. I again wish to thank Dr. Asitava Debroy, sir, for accepting our invitation to speak about this most practical topic. And also troubleshooters. Sir covered troubleshooters very well. I also wish to thank Dr. Kiran sir, Maruti madam, and Vijay Bhaskar sir for hosting this useful session. And also I wish to thank executive body members and IAPM AP association members for the solid support that has been extended to us for conducting this program. And last but not the least, all our virtual audience for the interaction. I request all the audience to provide your useful feedback for us, which will be sent by WhatsApp group by tomorrow. Thank you, sir, for this. Over to Kiran, sir.
Yeah, thank you, Kumar Guru sir, for very nice way of expressing your thanks to the speaker and the good words. Yeah, I also want to add that he has told so many aspects which I never heard of. I never took this blood transfusion things very seriously. And so today he has really enlightened us about all the deeper aspects and things which we cannot just ignore in the today's advancing blood banking technology. So it will be very useful to all of us. And now I request our president sir to please give his concluding remarks about the today's session and presentation. Please, sir, Vijay Bhaskar sir, please.
Dr. Debroy, once again, I thank you very much for your practical approach in the blood banking and blood product component usage. Actually, it's a very useful, to our postgraduates, especially to the young budding pathologists. As you said, this is a, hemotherapeutics. What you said is a very apt word, and practically useful to the clinicians in the management of the critical patients. Once again, I extend our thanks on behalf of the IAPM AP chapter. Okay, thank you.
Thank you, sir. And this will definitely inspire and motivate our postgraduates and other persons to take up this as a further super specialization.
Yeah.
Transfusion medicine and immunohematology, advancing. So your lecture will really help and inspire everyone. I am sure of it. Thank you very much once again, heartfully, for accepting our invitation and giving such a lovely and lively presentation and very enlightening also. Thank you very much.
Thank you so much, sir. Thanks everybody.
We will again expect you to come again to our session.
Oh, my pleasure, sir.
Yeah.
Your choice of topic. Okay.
Yeah, sure. Because so much to learn from him.
Actually, it's a very good practical topic.
Exactly, sir. Very practical importance. We are supposed to know.
Yeah.
So I think we have come to the almost end of today's scientific session.
Yeah.
And the feedback form, as usual, will be posted in the WhatsApp groups, and request all the members to give their valuable feedback so that we will further improve our these scientific sessions with newer topics and everything. So I think we will, and with this we end our today's session, and with a really heartfelt thanks to the speaker and all the participants who have really actively, participated and involved and witness this lecture. It will be again uploaded in the YouTube. You can be anyone who wants can watch it again. Thank you very much. Thank you,
Thank you.
Doctor.
Thank you. Thank you, sir. Thank you.